Hello and welcome back to the How I Rehab podcast. My name is Nick Kane. Very excited about our guest today in Liz Bayley. Liz is a specialist physiotherapist with an extensive experience working with dancers and performing artists, including shows such as Matilda and The Lion King, and obviously in high-level ballet dancers. She has a strong interest in the foot and ankle, which we touch on today. Liz has presented globally at many events around Europe and the world, and also presented for us at the Difficult Foot and Ankle event that we ran in Manchester last year. And she also has a masterclass coming up on the SportsMap platform around first MTP, joint pain and dysfunction, covering the associated pathologies there. In today's podcast, we chatted in more detail around hypermobility and the disorder that does affect a lot of people in some of their pain presentations, and something to be really wary of. Something that we haven't sort of talked on too much throughout some of our content here on the podcast and across the masterclass platform. And we also then move into chatting around posterior ankle impingement as just one of those signs and symptoms and issues that may present after a lateral ankle sprain down the track. And Liz provides some really great insights into how she might manage that as a condition. Now, I also just want to very briefly update you on the SportsMap events so you're not missing out on anything that might be coming towards you. Our Italy event on the hamstring, it's sold out, and that'll be running in a couple of weeks from the time of this recording. But we are super pumped to be heading to Boston in the USA for Fast Track the Injured Runner, featuring Brian Heiderscheit, Rich Willey, Colin Griffin, along with a range of other presenters for a really interactive 2 days. There will be practical and breakouts, and that's held at the track, which is the centre of New Balance. It's an amazing facility, so we're very excited to be heading there and really engage with some of our US audience and members, so we can't wait to see you all there. And we've also recently announced 2 smaller events in Melbourne and Perth with Michael Giacomas, and that'll be focusing around the thigh muscle injuries, so hamstring and quadriceps. Very limited places for those because they'll be very highly practical. They're a day and a half events. All those events are listed on the SportsMap website. So head over and have a look and stay tuned for more announcements coming with our annual conference in Melbourne, which will be early February, and then also some further developments in the UK around mid-June. Okay, let's get stuck into this podcast with Liz. Hope you enjoy and get something from it. Thanks for listening. Welcome to the How I Rehab podcast, Liz.
Hiya, nice to be here. Thanks for asking me.
No, it's great to have you on. Excited about our chat, and coincidentally, which wasn't even in some of our planning, your masterclass for SportsMap is coming out in about 3 or 4 days from the time of this recording. So we're excited about that. Can you give us a little overview of, I guess, what you touched on there? It was based around the first MTP joint.
Yeah, so it was based around the presentation that I did for you guys for the Difficult Foot and Ankle symposium last year. So it was when I heard difficult foot and ankle and the subject was the first MET or the first MTPJ, the first thing I thought of was sesamoid cases and turf toes. So the masterclass mainly focuses around those 2 particular pathologies, but we also touch on hallux rigidus, functional hallux limitus, what else? Hallux valgus. I don't think we talked about bone stress injuries. It was a while ago since I did it now, but the main things, it's really focusing on instability of the first metatarsal, the importance of the first metatarsal, particularly in sports, and how function can really go wrong when you have instability issues, particularly after turf toe type problems and chronic sesamoid cases, degenerative turf toe issues as well. And then I talk a lot about the rehab and how to really rehab a forefoot well, because that's something that gets missed, I think, quite a lot. Especially up to return to sport levels. So people can kind of rehab a foot pretty well, and then they get to a certain point and things get missed. And we're so good at rehabbing things like Achilles and ACLs, but the big toe and the forefoot often don't get rehabbed to the level they need to be at. So I talk a lot about the rehab for that as well.
Beautiful. It's extremely comprehensive, and I think everyone knows the difficulties with sesamoids and obviously a significant turf toe or plantar plate injury. So amazing masterclass, but we're not going to touch on that too much today. We're going to more talk around, I guess, some of the injuries that you see and deal with in dance. But I've jumped the gun on giving you a bit of insight into the masterclass. Tell us first a little bit about yourself, for those who don't know you, your background, and what you're doing now.
Yeah, so I am a dance specialist physiotherapist, and that effectively means that I also specialise in foot and ankle, because dancers injure their foot and ankle. 60-70% of the injuries that you'll see will be in the foot and the ankle. So when I first became a physio about 10 years ago, I was a sports therapist before that. So I've been working clinically for a while, 15, 16 years or something, but as a physio for about 10 years. And I realised I had to get good at the foot and ankle quickly, because dance that's all I saw, you know. So foot and ankle is a particular area of interest of mine, and I work in London. I work in the West End, so I used to work on some big shows, like I did Wicked for 3 years, and I was on The Lion King for 3 years. And lots of other different shows in the West End. And I'm now on Matilda the musical, which is a little bit less dancey. If anyone's seen it, I'm Miss Trunchbull's physio, effectively the character Miss Trunchbull. And then I also work at my own clinic in central London, which is where I am right now. And I work for a dance and music college in Greenwich in London 2 days a week.
Excellent. And we were just chatting offline around my wife, who was a professional musical theatre performer, and I know how the sought after the physios are, but also how, I guess, challenging some of the cases are in some of the dances and the performing arts. It's so different to, I guess, what I had personally dealt with before, being more sort of field sport orientated. So keen to sort of delve into a little bit of these areas around what sort of working in dance looks like. So I guess keen to sort of talk initially around what are some of the key common injuries that you encounter in professional dance. And, I'll reference just a recent study by Shane Kelly, who's done a masterclass and some work with us before, and that was on bone stress injuries having a high burden and severity in dance. That was the Royal Ballet. So I'm assuming you see a bit of bone stress, but fill us in on your take on that and other injuries that you would commonly see.
Yes, I definitely see a lot of bone stress injuries. It's another area that I'm particularly interested in. So when I get a dancer with a bone stress injury in the foot, I'm like, this is my area, so it's very specific. But yeah, bone stress injuries are very common in the West End and in ballet, in any kind of dance or aesthetic art form, as people will know. So we, interestingly, I was talking to someone else who deals with a lot of bone stress injuries, and I said, I don't think I've missed it, a hip or a pelvic or a sacral bone stress injury in a dancer. I haven't seen that yet. And like I said, unless I've missed it, but I don't think I have. Dancers tend to get bone stress injuries below the knee. So it's tibial and then everything below that. So fibula, talus, navicular, medial cuneiform, sesamoids, metatarsals. So I see that all the time. And it's possibly something to do with them getting more foot and ankle bone stresses, is to do with the way that they dance and jump, because they don't tend to use the hip in the same way as people in other sports, because they keep the trunk quite upright when they jump. So a lot of the force goes more through the foot and the ankle than the knee and the hip in certain cases. That's one theory that I have. I don't know if that's true. You do get, of course, lumbar spine bone stress injuries in dancers as well, so pars defects. Again, I haven't seen many of those. It's much more the below the knee type stuff. So medial tibial stress syndrome is something that I see so much, especially in the sort of just older than adolescent dancers that I work with. Like the 18 to 22-year-olds that I work with at the dance college that I work with in Greenwich. That's probably one of the main things that I treat there: medial tibial stress syndrome, tibial bone stress injuries, actually going into fractures. Also patellofemoral pain, interestingly. I'd say that's probably the next most common injury that I see. But one thing with bone stress injuries in dancers is you see it so frequently that you learn to really screen for bone stress injury risk factors in all of the patients that you see. So it just becomes part of your general questioning. You ask about sort of diet, lifestyle factors, previous injury history. Have they had a bone stress injury before? We know that that's a massive indication of whether they might have a second one. And then talking about menstrual cycles, fatigue, other injuries that they've had, tendinopathies. There's lots of screening that goes into that. I'll often talk to the girls about their menstrual cycles, when they started their periods, do they get regular periods, what contraception are they on, and trying to explain why that's important. So you definitely learn to be on the lookout for those injuries in this population. So that is definitely one of the most common things that I see. In terms of other injuries, again, it's really foot and ankle, but the most common one that I see apart from that would be ankle sprains. But then that would be the same for most sports that people work in. It's the most common MSK injury going anyway. And then in court sports, field sports, dance, ankle sprains are such a common injury. So that's probably the next most common thing that I see, or the fallout from ankle injuries. And it would be lateral ankle sprains, far more than something like a syndesmosis or a medial ankle sprain. And when I say fallout, I mean things like ankle impingement, chronic ankle instability, particularly posterior ankle impingement in dancers, which seems to be linked more to stability issues than anterior impingement. They're slightly different in that way. And because dancers have a high prevalence of hypermobility, which I know we're going to talk about, usually the stability issue is the bigger problem in the population that I see. So the posterior ankle impingement is more common. And also they're the dancers that are going into plantar flexion constantly. So that brings out those symptoms. It's actually not the mechanism of injury. People think it's because they're constantly pointing their feet that they get posterior impingement, but it isn't. It's the cutting and the shearing forces of the change of direction work that they do that actually causes the problems and the synovitis in the ankle. And then it's the repetitive plantar flexion that then makes them become symptomatic, but it's not the reason they get it, if that makes sense.
It does. Yep. Okay. So let's chat. You've probably given us a really nice overview there. I guess first we will come back to posterior ankle. I think talking around that sort of sequelae of a call it a lateral ankle injury and what happens from there if it's maybe not managed exactly how it is, or if they just go back into dance and some of the requirements is needed to perform there. But before we do that, let's just swing back to a little bit around joint hypermobility, which you mentioned. I believe it's quite common in performing arts, and having never worked in the area, I'd imagine that it's also an important aspect to, I guess, performance in some of the dance moves and what's required, but also, could probably predispose for some injuries. I guess, first of all, tell us a little bit about hypermobility in your own words with what it is, and then maybe from a lens around injury prevention with these types of athletes. What are you sort of looking for, and how can you play a role there in injury risk mitigation?
Yeah, so hypermobility is something that, again, I used to know it was prevalent in the population that I worked with, but when I started to read around it and understand it more, I actually saw it even more in the people that I was working with, because I knew what to look out for better, because it's so much more than just joint hypermobility, just lax joints. When people have a hypermobility spectrum disorder, it really does affect them systemically. So you start to really notice the other ways that it can present. One of the key things, of course, is that it presents as pain, musculoskeletal pain. So as MSK clinicians, we'll see a really high rate of people with hypermobility, because just by statistically, it's actually more prevalent in the population than we used to think. I've read different numbers about how prevalent it is. There was a study done in Wales recently where they quoted 1 in 500 people had a hypermobility spectrum disorder. Now, in dancers, I've also seen the figure of around 40 to 50% of the population having hypermobility. The people that I see in the clinic, out of all the patients that I work with, I say more than 80% of the patients I work with have hypermobility, because one, they're dancers, they're female. There's a slightly higher prevalence of hypermobility in females. What else? So they're dancers, but I also see the dancers that are in pain. So if you see what I mean, it spirals up so that all of those people funnel into the clinic because that's where they end up. So anyone who works in MSK physiotherapy is likely to see a lot of hypermobility just by the fact that hypermobility does present as an MSK pain problem a lot of the time, and particularly in populations like the ones that I work with. So today, my last patient that I saw before coming on this had hypermobility. She didn't know it. She wasn't a dancer, actually. But it's funny how so many patients that I work with that I get referred that aren't dancers also have hypermobility in some kind of form, or I'd say it was part of a problem for them. So some kind of hypermobility spectrum disorder rather than just being a generalized joint hypermobility. So it's part of their part of their presentation. And I can almost see it when they walk in now. I'm so used to working with people that you can see it in people, that you can see in the texture of their skin, the fact that the way they hold their posture sometimes, even the fact that hypermobility is linked with neurodiversity. So you tend to find, or anxiety and depression and other problems like that, and stress. So you kind of can tell someone's personality, whether they're stressed, if they're anxious, and then the way they sit, like I say, the look of their skin and things. And I think in my head, I think this person's probably got some kind of hypermobility. And as we start going down that path, they do. And today was the perfect example. So I had a girl, she was in her mid-20s, she had bilateral foot pain, she didn't know why, she'd seen lots of people. And I thought when she walked in that she looked a bit clumsy, which is going to doesn't sound very nice, and she had trouble finding the clinic, and just a few things put together. And I thought, I think she's got some kind of hypermobility issue. And I said to her, are you flexible? Are you bendy? Like when you were a kid, could you sort of do party tricks? And she said, well, no, not really. And I said, do you mind if I have a quick look at a few things? And the first thing I'll always do with people is a Bacon score, but just because it's easy, not because it's the best way to look for hypermobility, but it's quick to do. It doesn't take much time. So Bacon score is a great screening tool for hypermobility, but it's not diagnostic. So I use it as a screening tool. So I said to her, can you get your thumb to your forearm, your little finger to the ceiling? And she could do everything. And as soon as she did the first two, she said, I laughed. And I said, I thought you were going to be flexible. And she said, oh, I didn't realize. And then this particular patient, I went down a line of questioning. I actually think she might even have hypermobile EDS. That's how much it affected her. And she had no idea. We talked about gastrointestinal problems, intolerance to changing of posture, anxiety, neurodiversity. What else came up? Things like palpitations, skin texture. And she was positive on all of those things and had no idea that this was part of her medical sort of history. And I'm pretty sure that's part of her bilateral foot pain. So it helped me frame it in a way that she sort of could understand. I always try to tell them without sort of scaring them. And I say, I'm not diagnosing you because I can't. There is a way to diagnose EDS, and it actually requires going through certain types of questions, being a bit more specific. And then you actually need to rule out other connective tissue disorders as well. So you would need to rule out things and rheumatological conditions. So you can't really diagnose someone with EDS in one session, but you can have a very high index of suspicion that they might have something like that. So I said to her, I'm pretty sure you have a hypermobility spectrum disorder. That's part of your presentation. It's partly why your feet are painful. The other thing that rang a bell in my head was she said she had tried stiff-soled shoes, which had been recommended to her by a different person, and she hated them. And often people with hypermobility don't like stiff shoes. They don't like the texture and the feeling around their feet. So they're quite difficult to treat, because often when they have foot pain, you want to give them some kind of supportive footwear, but they don't tolerate it well. And it was one of the first things she said was, I'm better in a barefoot shoe. And I thought, she's definitely hypermobile. It's just a few things she'd said that I see a pattern through all the different people that I see. But she did respond really well to barefoot walking. Interestingly, she had an Asian background. Hypermobility is also more prevalent in Asian populations. That's another thing. And she grew up walking around in bare feet. So she liked barefoot. She would have hated it if I'd put her into a pair of Hokas or something. And she said she tried that and she hated it. So we went with taping to support her, flexible taping to support her sort of feet and ankles, to make her feel a little bit more comfortable and give her a little bit of a gentle hug rather than anything rigid. And then lots of mobility exercises and foot strength. And I hope that will be very useful for her, but she hadn't had that approach yet. Because we tend to try and throw lots of stability at people that have foot pain, and people with hypermobility often don't tolerate that very well. So I've gone down a rabbit hole, but it was just because I'd just seen this patient.
So you're still probably working your way through it, but yeah, certainly a very interesting case and very helpful. I'm sure I'm sure it probably sparks a bit of an interest in a lot of people listening around certain patients they might have seen with different bilateral presentations, and certainly something important to consider. If I swing back a little bit, so we're talking around a high index of suspicion with hypermobility disorder. And I might get you to just step me through a couple of those different tests again in that I might take a patient through who presents. And then I guess from there, sticking with around the foot and ankle presentations in a sort of dance artist, you mentioned then we're going to sort of work around our strengthening and not so much the mobility work. What sort of am I going to do in that area? How do I sort of, obviously we can't change their mobility disorder. There might be things you like looking to add adjuncts to, but what tools do you have that you think are going to help, I guess, prevent or manage sort of that pain presentations in a performing artist?
Okay, so the first part of that was diagnosing it, wasn't it? Or going through tests to try and work out if they have some kind of hypermobility spectrum disorder. So the Bateman score, as I said, is the one that most people know and use. It's a 9-point scale. The problem with that is it's very upper limb heavy. So most of the scores come from the upper limb. So if someone has lower limb hypermobility, it can miss things out. So someone can be hypermobile, but they can get a negative test on the Bateman score, which then people think, oh, they're not hypermobile, let's shelve it. But in actual fact, they are. That's just been missed. That just isn't a good way to test them. There are different cutoff points depending on the population too. So it's different for women, for men, for children. Like children need to get a higher score because children generally are a bit more hypermobile, and hypermobility drops with age. For example, women are more flexible than men, so the women's score also is slightly higher. For dancers too, I tend to put that higher for people to get to the right cutoff point. But on top of the Bateman score, there's also a lower limb assessment score. So it's a 12-point scale. Is it 12? Yeah, 12 points for the lower limb. And then there's an upper limb assessment score, which again, there's 12 points. And you have to score 7 out of 12 on each of those to be considered hypermobile, or that hypermobility is part of the person's problem, their presentation. What's good about that is it assesses the parts of the body in far more detail. And again, you can look those up. The what's the paper? Mayer and Chan, 2017, did some work on that. So if you want to look into more detail, like if you suspect someone's hypermobile but the Bateman score is not picking it up, you can then look into more detail, lower limb or upper limb. And I use the lower limb one all the time because I tend to see lower limb a little bit more. And that includes things like anterior jaw test, ankle dorsiflexion, obviously knee hyperextension, that's in the Bateman score. What else? Midfoot inversion, big toe extension, flat-footedness, which the patient I just saw had bilateral varipes planus. That's one of the scores on the lower limb assessment tool, which isn't in the Bateman score. So that's something else you can use. There's also something called the 5-part questionnaire, which asks 5 questions, and it's useful because it sort of does historical hypermobility, because often people were hypermobile when they were younger, but as they get older, they lose it. So I can't remember all 5 questions off the top of my head, but it talks about, can you now or could you ever do this? For example, touch the floor with your hands from standing. And there's some other things. Did you used to do party tricks when you were younger? Is another one of the questions. And if you score 2 out of 5 on the 5-part questionnaire, that would be considered a positive score. So these are more effective ways of catching someone's hypermobility rather than the Bateman score, which is now seen as not being a very good way to look for hypermobility, but it's a great first screening step. And then from there, you go into the questions around the systemic effects. So everything I just mentioned. So family history, dislocations is a really important one. If someone's ever dislocated their shoulder or their patella, think EDS. That's there's a very high correlation between dislocations of those joints and Ehlers-Danlos syndrome. Not just hypermobility spectrum disorder. They're not actually on a spectrum. Some people with hypermobility spectrum disorder who don't qualify for EDS can be worse affected systemically and quality of life than someone with EDS. It doesn't necessarily run that EDS will have worse symptoms. It's interesting like that. It's very individual. There was a paper published last year. What was the name of the paper? Oh, the author, Ewer, I think, EWER, 2024. They did something called the spider diagram, which takes into account the systemic features of hypermobility. The paper is very interesting. So the person can plot their symptoms on a diagram to see which part of their life is affected the most by their hypermobility. So for some people, it'll be their joint hypermobility, but for some people, it'll be the fact that they have POTS, which is tachycardia syndrome. So when they change postures, they lose blood pressure and they get dizzy. Or for somebody else, it'll be anxiety. Or for somebody else, it'll be, I'm trying to think what all 8, I think there's 8 spokes on the wheel. So the spider diagram is a great way to really assess how hypermobility affects someone's quality of life, not just simple joint hypermobility, because it's far more complex than that.
Yeah,
You did ask
okay.
about treatment, didn't you?
I sort of doubled you up on a question, so Maya, but that was really comprehensive. I think provides some great resources for us to delve a little deeper into the hypermobility spectrum to level up our knowledge a little bit. I guess I'll try to come back to like a clinical situation that you often potentially deal with. You mentioned the lower limb screening tool, and you're looking at some midfoot and the inversion and the other aspects you mentioned in a dance setting. So someone presents to you and they're showing signs of this around the foot. What are you putting in place? And I touched on it before around the strengthening or mobility and things like that. What are you looking forward to both put in place? We'll call it as an injury prevention, but we'll know that might tie into some of our management later. What can you do to assist that performer or athlete?
Yeah, so as I said, you see it in most of the people I work with. You're going to see it in some way. So there's there's a little bit of research coming around, like good quality research about how we can work with people with hypermobility. Like, can we strength train them? Because historically, and if you work with people, especially people with Ehlers-Danlos syndrome, maybe the more severe hypermobility spectrum disorder symptoms, often it feels like they don't tolerate resistance training very well, especially if you go in too heavy too fast. They can flare up quite easily. They tend to have high tissue sensitivity. They need longer recovery periods. So it's hard to know with those people how to work with them, because we're pretty sure that resistance training is important for them. And when you do it correctly, I think you can get some really great outcomes. And that's anecdotal, just from when I've worked, like I say, I work with them all the time. But even I know the evidence is there to show that we can strength train people with hypermobility in a similar way to people without hypermobility. There was a paper that was done by Benham. I'm going to get his name wrong. Benham Lingert. He's a Danish physiotherapist who works with shoulders and hypermobility. I presented with him in Copenhagen this year, and he was presenting his research, and it basically shows that hypermobile people, when you strength train them, they can progress just like people who aren't hypermobile. The difference between them is that they start at a lower level. So they have this sort of inherent weakness in the tissues. They just start lower, but they can get stronger with resistance training. And what they looked at was, do you train them with heavy load or lighter load? Because most people get a bit scared with hypermobiles and they'll give them lighter load. But he was trying to work out, is that necessary, or can we actually load them heavy? And what they found was, I forget which joint it was, I think it was the knee. They did knee and shoulder. They found that actually they had good outcomes with heavy training without any adverse reactions. The one thing they did get was transient headaches in the heavier load people, but they found that hypermobile people could tolerate heavier loads, which I think is really useful to know. I also like that I can say to hypermobile people, there is evidence to show that you will strengthen just the same as a non-hypermobile. We just need to start at a slightly lower level and get you there. But I will always be a little bit more cautious with anyone that has hypermobility, because you can definitely flare them up super easily. Like if you're going too heavy or too much range or too many joints or not enough recovery, that's one of the key things. Their ability to recover is slower. Like I spoke to the Australian ballet physio, very well known. You guys know her, Sue Mays. She's amazing and has done so much for dancers and hypermobility. But we had a chat about how when you train dancers, you have to give them a deload week. Hypermobile dancers, you might want to bring in a deload week earlier for those people, rather than, so say you had a training cycle of 5 to 6 weeks for most people before you have a deload. With hypermobile dancers, you might want to give them a deload week around week 4. And I thought that was interesting, because I've seen that too. That's what she said she found with the Australian ballet dancers, and that matches what I see as well. They get fatigued and they can't progress on past around week 4. They need to pull back a bit, and then you can progress them again. But they definitely need education around recovery strategies and rest, because they're not very good at resting. They tend to be fatigued. That's one of the symptoms that comes with hypermobility. So I think the best treatment, from what we understand, is probably some kind of resistance training, neuromuscular exercise, like it would be for anything, for injury prevention. Like all the FIFA 11 plus work has shown us that. But in younger younger dancers, but also in older people. We know that neuromuscular exercise has some good evidence for injury prevention and performance enhancement. Same for people with hypermobility. There's some evidence to show that we can train them in a similar way to non-hypermobile people, but I think we just need a bit more evidence, but it has to be individually tailored. So if you have one of those people that's hypermobile, but let's say they do have EDS, it does tend to present with more quality of life issues, more fatigue, more anxiety, and MSK, general pain. I would still take it easier with one of those patients than I would someone who didn't have that. That's just, I'm a little bit scared to push them too fast. I'll definitely strength train them, but I'll just go a little bit slower, a bit more recovery, a bit more education. And then we also know that proprioception is important for people with hypermobility. But that doesn't mean that you stick them on like a wobble cushion and that's your treatment for them. In fact, that's probably the worst thing you could do. So when you think about proprioception, it's a mixture of things. It's postural control, but it's also joint position sense, and it's also force sense. There's 3 different parts to proprioception. So I talk about this with ankle rehab. Like when we train proprioception in ankles, historically we've put people onto an unsteady surface. But from the way that I understand proprioception, i.e. joint position sense, that's one of the worst ways to train it. It does train postural control, but it can also make the person a bit more visually reliant. So you rely on your vision for balance a little bit. So I'm much more an advocate of training people on steady surfaces, but using things like perturbations and visual disturbance. And I'd say the same for people with hypermobility, because if they struggle with proprioception, if you then put them on an unstable surface, it might actually make them more dominant on their the other ways that they sense the world, that their vision, for example. So doing exercises in closed chain is important for people with hypermobility, not so much open chain stuff. And also allowing them to go to their end of range, because they do have, let's say, excessive or more than normal, quote unquote. What does normal really mean? Let's say statistically, they have greater than normal range of motion, but rather than keeping them in a normal range of motion, they have to use their range of motion. That's normal for them. So we have to allow them to use that as controlled as possible in a closed chain as much as possible. And the other thing I do is give them some feedback. So to begin with, I'll let them use a mirror, because it can help them a lot with their proprioception. Where are they standing? What position are they in? How far forward are they? Are their knees over their toes? Is their shoulder straight? And then transition to getting them to video themselves and watch it back rather than use a mirror. So they're not visually dominant. And then they start to feel it in their body a little bit, but it can be really challenging. But actually eventually getting them away from a mirror is really important, because dancers spend their life in front of a mirror. So if you have someone with hypermobility, they then rely on that mirror to know where they are in space. So if you can get them to start, like I say, using video of themselves to watch themselves back, it can be quite powerful.
Lovely. Some really good tips, and I think that might lead us into talking a little bit around the posterior ankle component. I never miss a chance to get a little plug in there, but obviously you mentioned Sue Mays. She has done a masterclass on chronic ankle instability for us as part 1 and part 2. So she's a top quality clinician, as you've mentioned. I love the feedback around the proprioceptive aspect and how you train that and taking the visual elements out of it. If we can maybe step through a process, you mentioned I've had an ankle inversion injury and sort of we're somewhere in the middle part of getting towards that posterior ankle impingement. What are you doing? What should we be doing maybe in that part to sort of stop us getting those signs? But if an artist presents to you with posterior ankle impingement and you're talking around, it's more related to the instability, which you mentioned at the start, how do we sort of get that back to symptom-free?
It's a very good question, because posterior impingement can be really persistent sometimes, and I often see some of the more difficult cases that don't get better. That's, they'll be the ones that I get asked. I was asked to go and see one, for example, in a in a ballet company in the UK recently. They got me to have a look at one of the dancers who had done everything, and they have great physios at this company and they couldn't get her better. So they asked my opinion. They can be really persistent when they don't improve with what you would expect them to, load management, maybe some anti-inflammatory medication, bit of balance training, bit of ankle strength, calf strength, off you go. That's what you would hope would get better. But the persistent ones tend to be the ones, I think, that have a little bit more stability issues. So often hypermobility is part of that. But you can certainly get ankles that are mechanically unstable. So when you test them with an anterior draw test and a talar tilt test, they are lax, quote unquote lax. So they have, well, if you think about it, the anterior draw test, a positive anterior draw test is a requirement for the lower limb assessment score for hypermobility. So if you've got someone with hypermobility, whether they've sprained their ankle or not, they're probably going to have a lax anterior draw test, if that makes sense. So if you've got mechanical laxity on those tests, you can have that, but still have great functional stability. So the person is able to control their ankle at end range, mid range, jumps, landings, all that kind of thing. And that's what you're trying to get them back to. So with stability work, one thing that I've started probably in the last 6 months bringing in is looking a little bit more at pronation and supination as a movement to really train that movement, because that's the subtalar joint, right? So trying to get, because we always try to keep the foot in such a neutral position when we train it. Like historically, you kind of say, lift the arch, stay strong, don't let the foot drop, because that, I think that goes back to us demonizing pronation as a movement. We always think of it as being a bad thing. But if you watch a really accomplished dancer or a really good runner, they pronate like crazy when they land or when they push off, because it is a necessary part of our movement. So I've learned that actually training full range pronation, supination can be with body weight. So I'm not talking about with bands. So using incline boards or like half a Bosu ball flipped the other way, and taking the person into their end range pronation, supination with body weight, really gets them much stronger in those positions, and it can help stabilize that subtalar joint functionally when they have to actually use it. There's no point in trying to keep them out of pronation, because they have to use pronation. If they're going to land a jump, they need to pronate. It's not normal otherwise. And then you start to get, and you get impingements, for example, if someone doesn't. I've seen that happen where dance teachers have said to a dancer, don't let the foot drop, which if it's excessive, I can see where they're going with it. But it's not the amount of pronation, it's the person's ability to control it, I think, from what I can see. So if you can retrain those movements, it has a better outcome with posterior impingement. So the key thing is you have to keep them out of those ranges until everything calms down. I know Sue Mays talks about this all the time. Synovitis in the subtalar joint or the talocrural joint is one of the key reasons we get posterior impingement. And historically, it's been blamed on things like os trigonums or a Steeder process, which is an elongated tubercle of the talus, the lateral tubercle of the talus. But if you think nearly 30 to 50% of the population has those kinds of morphologies, they're not deformities, they're just a normal part of anatomy. They have them in the ankle. And if you have a 23-year-old footballer or a dancer who suddenly gets posterior impingement, well, they've had an os trigonum since they were 11. So is that really the problem? Or is it just that they've had an increase in load? They've sprained their ankle. They've now got synovitis in the subtalar joint. And that's what's impinging on the os trigonum, So getting the synovitis down is key. So oral anti-inflammatories and steroid injections, I know, very, very effective for posterior impingement into the right part of the joint. Keeping them out of that range, working their stability like crazy, like I said, supination, pronation, dynamic balance, and keeping them strong in the calves, but without going into full plantar flexion. So floating heel type work for the calf. Sometimes dropping into full dorsiflexion can be irritable for posterior impingement because the capsule is irritated. So you might want to stay out of end range dorsiflexion and plantar flexion, depending on the stage they're at. But floating heel work will get them to keep that calf strong to a certain point. And anyway, we know that the calf produces most of its force in dorsiflexion. So if you can work the calf from dorsiflexion to just past neutral, that's really worthwhile doing while they're improving. If they don't have end range plantar flexion yet, that doesn't mean you can't work their calf, and it shouldn't mean you should do that. And then looking at their position for dancers when they're on their demi point or their point. Remember that it's not just female dancers that get posterior impingement. It's just as prevalent in male dancers. We assume it's to do with the point work for dancers, but male dancers get it just as much. So it can't be the point work. It's the demi point work. It's just the fact that they're on the ball of the foot. So, and remember, male and female dancers do a lot of change of direction work. That's the problem. It's not the plantar flexion as much. So I've lost my train of thought. What was I going to say? Talking about calf. Oh, position on point. So so make sure that when they're rising, they're not what we call either sickling, so taking the foot to the outside edge. That would also be known as low gear propulsion in like podiatry or lower limb physio. And they're not too much in high gear propulsion, which is through the first and second metatarsal, which is in dance, we call it fishing the foot or winging the foot. And often dancers will do that because it looks nice, but then that can cause lateral impingements. So looking at placement on demi-point or full point is important, retraining it, getting even distribution through all the metatarsals when they're in those positions. And then for people who aren't dancers, it can just be just the ankle control. It's the change of direction work, the plyometric stuff, the push off. So rehabbing it back to sport, thinking that it's the cutting and changing of direction that you need to work on just as much as calf strength.
Very nice, very comprehensive. Yes, certainly, the change of direction that, from field sports, you'd see it a lot, along with like the kicking the balls in soccer and football. I think most of that, I think we can probably visualize trying to hear you speak as work our way through the calf and some of the stability work. But I'd love you to just talk us through a little bit more of your closed chain, because, the supination, pronation, and the control around subtalar joint, and maybe just take us through one or two, a detail of an exercise or two that you would coach through, and how you sort of get the most out of that. You mentioned the wedges, and I'm just keen to get a bit more of a visual on how you go about that, so we can then apply it to someone I might be working with.
Yeah, so if you have no equipment at all, you can just get somebody into a single leg stand and just get them to access their pronation and their supination. Really simple. From that point, and then you do some kind of balance exercise, but more dynamic than just a closed eyes standing on one leg. So I love the Y balance, or the modified star excursion balance test. It's a test, but I use it as rehab all the time. So because it is dynamic, you're reaching in a few different directions, and it challenges different parts of the foot depending on which direction you're reaching in. So variations on the Y balance are really important. So that would be the next thing I would bring in, so long as they could tolerate it. If they weren't able to, if it was really irritable and they couldn't even dorsiflex or maintain that, then we'd stay in a single static balance. I wouldn't bring in a wobble cushion at that point, though. Unless it was very chronic. I do use wobble cushions for chronic ankle instability, but not acute ankle instability. And I suppose posterior impingement does come hand in hand with chronic instability. So you could use it there, but I would still stay away from just a wobble cushion balance. I don't think it does what we think it does. I think it's more useful to challenge the foot on a stable surface, but at different positions. So that's where I would use the slant board or the incline board. So I'd get the slant. So it works the side of the foot, which is down the slant. So if you're standing on an incline or a step with one step under one side, if the slant is on the inside of the foot, it's going to work the medial foot. And if the outside of the foot is down, so reverse it, it'll work the outside of the foot, so the perineals, for example. So if we're going with pronation, just on a simple incline board, I get the person to really access that pronation. So drop, allow the foot to drop, let the arch drop, go down the slope, keep going, even add a little bit of knee bend with that. So go right into it and then reverse it and pull back up. And they'll start to feel their tip post working really hard when they do that, and get them to push down through their big toe. You get a bit of FHL activation as well. So all the muscles, and intrinsics too, all the muscles that work the arch of the foot. Abductor hallucis is another one, flexor hallucis brevis. Then again, so mobilize it, drop down, keep going, pull back up, and do that. So if you're the other thing is the stiffness of the subtalar joint. Let's go with strength to begin with. So let's say we're stabilizing a lax subtalar joint. I do this more with strength in mind, so slow and heavy. I'd load it if I could as well, add a kettlebell or something to it, in and out. So depends on their sensitivity and their tolerance and their stage of rehab, but something like 15 repetitions of that. Then I get them to pull up to neutral and then make it into a balance at that point. So they're already fatigued, but then if you get them to take their hands off the counter or the wall, because it's not a balance yet, it's a stability exercise. That's the really important thing. We're working with stability, so they're not trying to balance, they're trying to access that range of motion. Then when they're good and tired, then give them a balance at the end. It's a really nice endurance thing that you can stick at the end, and their foot fires up like crazy. And I'd balance for about 20 to 30 seconds. Then I'd do it on the other foot, and then I'd come back and do that 3 or 4 times on each foot. By the end of that, the tib post, the FHL, the intrinsics are really working quite hard. And then you can reverse that for supination or for the lateral part of the foot. So where you put the outside, the fifth toe would be down the slope, and you would do the exact opposite. So you'd access the supination and pull back up against it, which uses the peroneals. 15 or so strength reps. Not strength reps, it's not strength, it's endurance because it's too high, but you know what I mean. Strength endurance. I know we're not allowed to use that word, but so 15 or so reps till they get to fatigue, then a balance. So that's great for strength. If it's a stiffness issue, because you can get stiffness in the subtalar joint, which then limits how the foot goes up into plantar flexion, particularly in dancers, and you can find stiffness either with like a medial glide to the subtalar joint or a lateral glide. And the way you assess that is you get the foot into dorsiflexion, you cup the heel, and then you press either medially or laterally that's covered, I think, in Sumez's masterclass, I'm sure. But if you actually find there's stiffness in one particular direction, then you can mobilize that, and that can make a huge difference to a really chronic posterior impingement, where you get them to rise up, it hurts, it's painful. Mobilize the stiff direction. Don't guess, assess it, find out which part is stiff, and then mobilize that, and then retest it. And often that gives them some really good relief. So you can use the incline board then for body weight mobilizations. So you might not do as many, or you might not weight it, but you'd be doing it more to access that stiffer range. So I do it either way. So I can use it for strength or mobility. Then I use the Y balance, like I said. So if I feel like they need to get more pressure through the medial foot, say they're rolling up to the outside, I'll put a band underneath the big toe and just stretch it a little bit so that if they lift the big toe up, it pings back, right? So that's a nice way to get them to really press through the big toe if they're not using the medial foot well. The other progression that I use is I do a heel raised Y balance, which is actually part of the dance specific star excursion balance test that actually exists. There's a dance specific version of it. And what you do is you put the heel onto a yoga block, and then you do the same thing. So you reach forward, posterior medial, posterior lateral, but it's in a rise position. So it just challenges the foot in a different way. It's a progression because the tib post and the peroneals have to work really hard to stabilize the ankle there. It's also nice because you're putting them into plantar flexion, but probably not full range, but you're getting them up into that position, which might be irritable for them. So they're starting to control it in that range. So that's a good reason to progress it like that. And then for dancers, the other thing I do is a star excursion balance test, but in a point shoe. So ballet shoes, if you've ever worked with dancers, point shoes particularly are very, they have like a rounded bottom and your foot almost rocks on them. It's crazy that ballet dancers can do what they can do in those shoes because they're so unstable, because they literally turn the foot into a block and it pronates and supinates, and you can't use the toes to stop that. So the ankle has to be so strong. But if you do the Y balance in a point shoe, it then helps them to access their stability as they're going to use it in their sport, if that makes sense. The thing you have to do with that is you must do it in a turned out position. Doing it in parallel is almost impossible. You just can't access the ankle control in the same way. So that, like I said, that's part of the dance excursion balance test. The dance modified star excursion balance test, sorry. Yeah. So once they've got a bit better dynamic stability, then I'll start to work on lateral movement, so bounding, skater movements, those kinds of things, then changing that to forward leaps, forward leap and holds, hops to stabilization exercises, really useful. That's McCohen, I think, 2008, did a paper on chronic ankle instability and hop testing. So you put sort of discs out, and then you hop from disc to disc, stabilize in between, change of direction, hop forward, hop back, hop side. And then you can even add in the reaches. So you can hop forward, stabilize, reach back, come back to neutral, hop back, and then repeat it. So it's just lots of change of direction work, but still very controlled, not scary or dangerous for people because it's a nice controlled environment. And then start to add a little bit of chaos. So you've got your control to chaos theory, haven't you, of getting back to sport, particularly for your field sports. Not so much in dance, it's not quite the same as rugby in that way. But then start to bring in mental tasks. So actually rehabbing it a bit like an ankle sprain. And then add in more changes of direction, a little bit more dynamic movement, so agility type work, stops and starts, get people to absorb energy, get people to produce energy. Absorption is really important. What else? Does that cover most things?
Yeah, definitely. I think it does. Like, obviously, we're hard to be in a podcast and cover everything, but I think that just gives hopefully a few more little pearls we can utilize in our rehab and take the athlete through. And clearly, it comes back to that sort of pronation, supination control, and making sure they have reduce the stiffness there. And I think you've sort of given us some really great insights. I feel like I've done this too many times in this podcast around referencing other things, but I think the hop test you mentioned around the forward and back with the cones was sort of covered in Eamon Delahunt's ankle instability masterclass. I'm trying to think back, and certainly Stu Eimer may have done a podcast with us, or he presented at a course around some the subtle instability of the subtalar joint. So it's sort of, it evolves in the importance of what we're dealing with, and that was on the back of sort of a deltoid ligament sprain. So it's something that we really need to factor in, I'm sure. So some great tips. Do you think, is there anything that we haven't really covered in what we wanted to sort of chat around and get some points across for people listening?
Just trying to think.
I think you've done a pretty good job, but if there was something you wanted to sort of pass on to anyone else, I guess now's our chance.
Do you know one thing, I suppose, because I see a lot of second opinion and even third opinion type cases, and quite often I'll say to them, okay, what have we done so far? I did some physio. Okay, what was it? Because it could be literally anything, couldn't it? And they say, I did some rehab. Okay, what was it? Oh, I did something for my foot. And I'm like, okay, what was it? So you're trying to get it out of them. What did they actually do? And often people have sent to me saying, we've done physio, we've rehabbed them, and they're still not better. And then when I really assess them, they're not strong enough. They're just not even close to meeting the point where they need to be considered rehabbed. And this is including sport people too. I saw a professional footballer not that long ago whose calf strength was down, his inversion knee strength wasn't great, his foot strength wasn't good. There was lots of stuff they could have worked on, and they just sort of needed me to go, this isn't good enough yet, get this better. So there's certain markers that I want people to get to, calf strength wise. I mean, there's lots of talk. I know Seth O'Neill talks about this a lot. Sancho did a good paper about it. If you don't have equipment, just getting people to be able to do a 6-rep max seated calf raise with 1.5 times their body weight. And so many people that come to me where that's an important part of their rehab, because that isn't everyone that I see, but anyone who does sport, again, professional athletes that have come to see me where when you test them seated calf raise isometric, they don't have over 1.5 times body weight, not even close to 2 times body weight, which would be more desirable for the kind of sport they're doing. And they have poor eccentric control. And like I say, they don't have good foot strength. And you would expect people when they're doing lunges and sprint work and to have strong feet. But actually, when you test it and you look at their big toe strength, whether that's with a manual muscle test or with a handheld dynamometer or with the force frame, which is a far better way of testing it, there's work to be done there on that individual part of the body that can bring their performance up. So it's what I talked about in the difficult foot and ankle, was how important the big toe is. But if the big toe has 40% of the foot musculature dedicated to it, because we need it to be able to push off and change direction and sprint. But when you have these athletes that have to do that and they don't have good big toe strength for whatever reason, and then someone tells me that they're fully rehabbed, I think, well, they're not. We can do this, which is great because I have to find something that we can do with them. But I suppose it's just saying to physios who rehab people, when you're about to say to someone's fully rehabbed, just consider if they are, because that's great. I'm happy to find those deficits, and that's brilliant. It gives me something to work on. But there's good data out there for normative values, for the calf. For the big toe, there's less. There's a little bit that's coming out. I think in the next 5 years, there'll be more around that. But depending on how you test it, the normative values are different. So it's very difficult for me to give you an exact number. I talk about it in my masterclass, actually. If you test with a handheld dynamometer, the foot in 20 degrees of plantar flexion and the toe in neutral, you would want around 2.5 newtons per kilo of body weight. But if the foot's in neutral and the toes are extended, that number goes up to 4 newtons per kilo of body weight. So it's impossible to say this number. It depends how you test it. And again, looking at inversion, eversion strength, tib post versus tib ant ratios. Even if you don't have equipment, just doing a simple single leg heel raise test. Often you can find so many things that you can work on with rehab: control, endurance, eccentric control. Does the person shudder on the way down? That's something I learned from Seth O'Neill, which I thought was interesting. You see that often, don't you? When people come down in the calf raise, they kind of judder, and that loss of eccentric control, that's something that you can rehab, because that can affect an Achilles tendon health.
That was good. That was a lot. So your inversion, eversion, I like the stuff around firstly the first toe, and there is some information evolving and testing strategies around that. But we won't go into further detail on that because it's in the masterclass and you've sort of touched on it there. Inversion, eversion, do you look for just 1-to-1 ratio? And are you testing that in neutral, and is that isometric?
Yep. So if you look at some of the research or what generally gets used, 1-to-1 ratio is something that I've heard and that I would look for. If you want to look at like the whole of the ankle control, so bring in tib ant with that, then if you're looking for percentage of body weight, I can't think who I heard say this, but I use it all the time. The tib ant should be able to produce around 45% body weight and tib post around 35% body weight. So that's a useful sort of normative range. That's for an athletic trained person though, not for your little old ladies or very delicate dancers. But yeah, the 1-to-1 ratio is useful. And then I would be testing it more in plantar flexion, because if it's in neutral or dorsiflexion, you get a lot of activity from the long toe extensors and also the ankle extensors as well. So if you're trying to test, let's say, eversion strength, so the perineals is what we're really looking at. Now, functionally, yeah, the extensor digitorum longus also evert the foot. So if you're looking functionally as a group, putting it into more of a neutral position, we'll test it as a group. If you want to isolate the perineals a bit more, then I'd want to test that in plantar flexion. So I often test both. And it would be the same with inversion. So if you really want to isolate tib post as much as possible, a bit more plantar flexion. And you can watch the tendons. You can see which tendon's working. You can see if someone's overusing or using their tibialis anterior more to get that inversion strength. Or when you do functional things with people, you can see if the tib ant is sort of working over time, particularly if they've got a weaker foot or tib post tendinopathy. You see that quite often. So that's something I'll talk to people about when I rehab them. And if they're doing some kind of foot strength exercise or tib post exercise, I'll show them the tib ant tendon and say, try not to let that muscle pop. This is the one we want. Just if you want to really bias a particular muscle. And I know there's an argument for just training the movement and the group, but sometimes you want to bias an exercise a bit. Like with the foot, we can't isolate the intrinsics, but we can bias them. And in some populations, people with pes planus, hypermobility, you do want to bias the intrinsics because they tend to be weaker relative to the extrinsics. So if you can bias it, then that's a bit better.
Excellent. No, I like the movement into, I guess, the field sport. I think from my experience in field sports, unless someone's really honing in on the foot, and that's usually only happens after an injury, if they've been in the boot or something's happened, they might. Then most of them have got no idea around anything to do with FHL strength inversion. So it's certainly very much an underutilized sort of space. Clearly it's an area that we could all probably evolve and do better in, considering the demands. Liz, very enjoyable chat. Thanks for jumping on the podcast. You do have patients not too far out of your door in waiting for you. Again, really excited to bring your podcast and your masterclass out. Trying to, I guess, upskill those out there dealing with foot and ankle conditions and those who have an interest in around the performing arts. So thanks for passing on your insights.
Thank you. Thank you so much for having me. It's an honour to be part of the series now.